morning everyone, my name is Nicole Tricia Bickinson. So today, mo din ako ang topic about the transmission and pathogenesis of tuberculosis and tuberculosis outcome. So introduction. So the TB is an airborne disease caused by bacterium, Microbacterium tuberculosis, and seven very closely related microbacterial species. Microbacterium africanum, Microbacterium microti, Microbacterium capri, Microbacterium pinipidi, and Microbacterium caniati, and Microbacterium mungi together comprise that is known as the Microbacterium tuberculosis complex. Most, but not all, of these species have been found to cause disease in humans in the United States. The majority of TB cases are caused by Microbacterium tuberculosis. Microbacterium tuberculosis organisms are called tuberculobacilli. So, mo ni siya ang kanang picture. Transmission of TB. So, tuberculosis is carried in the airborne particles called droplet nuclei of 1 to 5 microns in diameter. So, infectious droplet nuclei are generated with person who has pulmonary or laryngeal TB disease, cough, sneeze, shout, or sing depending on the environment. These tiny particles are remain suspended in the air for several hours. So that bacterium tuberculosis is transmitted through the air, not by the surface contact. So the transmission occurs when a person inhales droplet nuclei containing tuberculosis and the droplet nuclei transverse the mouth or a nasal passage, upper respiratory tract, and bring it to reach the alveoli of the lung. Tuberculosis is carried in an airborne particle called droplet nuclei of 1 to 5 microns in diameter. Infectious droplet nuclei are generated with a person who has pulmonary or laryngeal TB disease, cough, sneeze, shout, or sing. So, parehara siya. The transmission of TB is spread from the person to person through the air. The dots in the air represent droplet nuclei containing tuberculobacilli. So, money. Factors that determine the probability that tuberculosis transmission is factor and description. Susceptibility. Susceptibility is immune status of exposed individual. So, infectiousness of the person with the TB disease is directly related to the number of tuberculobacilli that he or she expels into the air. Persons who expel many tuberculobacilli are more infectious, and the patients who expel few or no bacilli. Third is environment. So, in the environmental factors that affect the concentration of tuberculosis organism is then exposure, proximity, frequency, and duration of exposure. Characteristic of the patient with TB disease that are associated with infectious. The factors and descriptions. Clinical. Presence of cough, especially lasting 3 weeks or longer. Respiratory tract disease, especially with involvement of the larynx, highly infectious. Failure to cover the mouth and nose when coughing. Inappropriate or inadequate treatment, drug, or duration. Procedure. Undergoing cough-inducing or aerosol-generating procedure, bronchoscopies, sputum inductions, administration or aerosolized medication. Radiographic and laboratory. Cavitations on chest radiograph, positive culture for M. tuberculosis, positive EFP sputum smear result. The infection of a person with TB disease is directly related of the number of tubercle bacilli that he or she expel in the air. When a person who expel many tubercle bacilli are more infections than the patient who expel few or no bacilli. Factors and description. So, concentration of infection is droplet nuclei. The more droplet nuclei in the air, the more probable that microbacterial tuberculosis will be transmitted. Space. Exposure in a small or enclosed space. Ventilation. Inadequate local or general ventilations that result in insufficient dilutions or removal or infections, droplet nuclei. Air circulation. So, recirculations of air containing infections, droplets, or nuclei. And specimens handling and proper specimens handling procedures that generate infections, droplet nuclei. Air pressure. So the positive air pressure in infectious patients' rooms that causes microbacterial tuberculosis organism to foul the other areas. So proximity and length of exposures, that factors that can affect transmission of tuberculosis. The factors and description is duration of exposure to a person with infections with TB. So the longer of the durations of exposures, the higher the risk for transmissions. And then frequency of exposure to infections in persons. So the more frequent the exposure, the higher the risk for transmission. So rehara siya sa infections TB. And then the physical proximity to infections persons is the closer the proximity, the higher the risk for transmission. So young children with pulmonary and TB disease are less likely than adults to be infections. This because the children generally do not produce sputum when they cough. However, transmission from the children can occur. So therefore, the children and adolescents with the TB disease should be evaluated for infectiousness using the same criteria as the adults. So these criteria include the presence of the cough lasting 3 weeks or longer, and cavitations on the chest, radiograph, or respiratory tract disease with involvement of the lungs, airways, or the larynx. Infections, pathogenesis of TB. So the infections occurs when a person inhales the droplet nuclei containing tuberculous bacilli that reach the alveoli of the lungs. These tuberculous bacilli are ingested by alveolar macrophages that the majority of these bacilli are destroyed or inhibited. A small number may multifold intracellular and are released when the macrophages die. If alive, this bacilli may spread by way lymphatic channels or through the bloodstream to more distant tissue and organs. So they're including the area of the body which the TB disease is most likely to develop regional lymph nodes, the apex of the lungs, the kidney, the brain, and the bone. So this process of disseminations primes the immune systems for systemic response. Further, the details about pathogenesis of the latent tuberculosis, infections of LTBI, and TB disease are described in figure. So, the pathogenesis of latent tuberculosis, infections, and TB disease. So, as you can see at the picture, first, area of the detail boxes 2 to 4 and 5. Arikam. The droplet nuclei containing tubercle bacilli are inhaled, enter the lungs, and kanang travel adto sa imong alveoli. The bronchial tuber bacilli manat siya ang kanang kinaunhan nga pan. And then kaning then alveoli, the tubercle bacilli multiply and the alveoli. 3. The brain, the larynx, the lymph node, the lungs, and spine, and kidneys, and then bones. The small number of tubercle bacilli enter the bloodstream and spread throughout the body. The tubercle bacilli may reach any part of the body, there including areas where TB disease is more likely to develop, such as the brain, the lymph nodes, the lungs, spine, the bones, and the kidneys. And 4 is special immune cells from the barrier shells. In this example, bacilli are in the lungs. So within 2 to 8 weeks, the immune system called macrophages linges and surrounds the tubercle bacilli. The cells from the barrier shells, it's called the granula, that keeps the bacilli contained and under control of Latin tuberculosis infections. 5 is shells breaks down to tubercle bacilli, escape and multiply. If the immune system cannot keep in the tubercle, the bacilli under control, the bacilli begin to multiply rapidly, a TB disease. This process can occur in the different area in the body, such as the lungs, the kidneys, brain, or bone. Latin tuberculosis infections. The person with the Latin tuberculosis infections have or microbacterial tuberculosis in their bodies, but do not have a TB disease. It cannot spread in the infection to the other people. A person with a Latin tuberculosis infection is not regarded as having a case of TB. So the process of the Latin LTBI begins with its extracellular bacilli are ingested to macrophages, and it presents to other white blood cells. So this triggers the immune system response, in which white blood cells kill and escapulate most of the bacilli, leading to the formation of granula. And at this point, Latin tuberculosis infection has been established. It may be detected by using the tuberculin skin test or an interferon gamma release testing for tuberculosis disease and infection. It can take to 2 to 8 weeks after initial TB and infections for the body immune system to be able to react to tuberculin, and for the infections to be detected by the tuberculin skin test or kanang interferon gamma release assay. Within weeks after infection, immune system is usually able to halt the multiplications of the tubercle bacilli and if preventing further of progressions. So the person with Latin tuberculosis infection have or microbacterial tuberculosis in their bodies, but people have TB disease cannot spread the infections to the other people. So in some people, the tubercle bacilli overcome the immune system and multiple, resulting in progression from LTB or TB disease. Persons who have TBs are usually infections and spread bacteria to other people. Then the treatment for the Latin tuberculosis infection positive culture for tuberculosis confirms the diagnosis of the TB, indicates The person who have TB disease may spread the bacteria to the other people. Monitor ang progressions of the TB. People who are exposed to microbacterial tuberculosis may or may not develop the latent tuberculosis infections. People with latent tuberculosis may have or not develop the TB disease. People exposed to microbacterial tuberculosis infected with microbacterial tuberculosis. The no is negative TST or NGI or aerosol does not develop of LTBI or TB disease, and the non-infections as yes positives or TST or AGR result, normal chest radiograph, walay symptoms, has LBTI not infectious, may develop symptoms later in life, abnormal chest radiograph, symptoms may have positive culture, has TB disease, or may be infectious. So, latent tuberculosis infectious versus TB disease. So, the person with infected sa latent tuberculosis has a small amount of TB bacteria in his and her body that are alive but dili siya inactive. Cannot spread the TB bacteria to others. Hindi makaspread yung bacteria to sa uban. Does not feel sick but maybe become sick if the bacteria become active in his body. So, dili ka masakit pero usually has a TB skin test or TB blood test reaction indicating TB infections. The radiograph is typically normal. The sputum smears and culture are negative. Should consider treatment for latent tuberculosis to prevent TB disease. Does that require respiratory isolations? Not a TB case. Person with a TB disease infections so has a large amount of the TB bacteria in his or her body, so may spread bacteria to others. So, makatakod din sa labang tao, katag. Then may feel sick, may have symptoms such as cold, fever, or weight loss. So, pati ka ng sakit, murag sakit kay nga kanang makakuan ka og kanang hilantan or kanang cold or kanang pagkuan sa imong weight loss. And then usually has a TB skin test or TB blood test reaction indicating TB infectious. And then radiograph may be abnormal. The sputum smears and culture may be positive. Needs treatments for TB disease. So, kinahanglan jud siya treatments para sa kanang TB disease. So, may require respiratory isolation at TB case. So, risk of developing of tuberculosis disease over lifetime is without treatment. Approximately 5% of persons who have been infected with tuberculosis will develop disease in the first year or 2 after infections. Another 5% will develop disease sometimes later in life. Those without treatment, approximately 10% of persons with a normal immune system who are infected with tuberculosis will develop TB disease at some point in their lives. So, the site of the TB disease. TB disease can occur in pulmonary and expulmonary site. Pulmonary. So, the TB disease most commonly affect the lungs. This is referred to as pulmonary TB in 2011. 67% of TB cases in United States were exclusively pulmonary. The patients with pulmonary TB usually have the cold and abnormal chest and radiograph and may be infectious. Also, the majority of the TB cases are pulmonary, so the TB can occur almost any anatomical sites or the disseminated disease. Extrapulmonary TB disease occurs in places other the lungs, not including the larynx, the lymph nodes, the pleura, the brain, the kidneys, or the bones and joints. In HIV-infected persons, the extrapulmonary TB disease is often accompanied by the pulmonary TB. The person with extrapulmonary TB disease are usually not infectious unless they have one or pulmonary disease in addition to extrapulmonary disease too. So the extrapulmonary disease is located to the oral cavity or the larynx, or the extrapulmonary disease that includes in the open abscess or the lesions in the which concentrations or the organism is high. So especially in the drainage from the abscess of or lesions in extensive, or the drainage fluid is aerosolized, that the person with the TB pleural uh, effusion maybe have underlying pulmonary TB that is masked on the chest radiograph because the the ex- the, ex- the effusions of fluid decompress the lungs, and then the patient should be considered infectious until the pulmonary TB diseases are excluded. So miliary of TB. So the miliary TB occurs with the tubercle bacilli enter the bloodstreams, and it disseminates to all parts of the body. So where they are grow, and then it causes disease in the multiple sites. This condition is rare but serious. So the miliary refers to the geographic appearance of millet seeds. It's scattered through the lungs. It is the most common in the infants and the children that younger 5 years or age, youngers of age. And several compromise that the person's miliary TB have detected in the individual's organs there, including the brain and the several organs, or to treat out the whole body, so that the condition is characterized by a large amount of the TB bacilli. So although it may easily be missed, and it's the fatal, and if untreated, up to 25% of the patients with miliary TB have the meningeal involvement. So, the central nervous system. So, when the TB occurs in the tissue surrounding the brain or the spinal cord, it is called the tuberculous meningitis. That tuberculous meningitis is often seen at the base of the brain. So, the imaging the studies, the symptoms is include the headache, it decreases the level of consciousness, and the neck sickness. The duration of illness before diagnosis is variable, and it relates in the parts to the presence of or absence or of the other sites of involvement. In many cases, so the patients with meningitis have abnormalities on the chest radiograph consistent with old or the current TB, and they often have miliary TB. The risk of the Latin tuberculosis infection progressing to the TB disease. So anyone who have LTVI or can and develop the TB disease, but some people are higher risk than others. The person increased risk of progression of LTV to TB disease is a person infected with HIV, so the children younger than 5 years of age, person who have recently infected with microbacterial tuberculosis within the past 2 years, the person with history untreated or inadequately treated the TB disease, by including a person with fibrotic chains on a chest radiography, and then consistent with a prior TB disease, person who have receiving immunosuppressive therapy such as a tumor or necrosis factor alpha, TNP, or pathogenesis, the systematic corticosteroid equivalent to greater than 15 mg of prednisolone per day. So the immunosuppressive drug therapy following organ transplantation. The person with silicosis, diabetes mellitus, chronic renal failure, leukemia, or cancer of the head, neck, or lung. person who have the gastrectomy or jejunal bypass, the person who have with less 90% of their ideal body weight, cigarette smokers, and a person who abuse drugs and alcohol, and population defined locally is having increased incidence of disease due to microbacterial tuberculosis, including the medically underserved, the low-income population. The risk of the developing of TB disease is the risk factor is the TB infections are no risk factors. So about 10% of over of the lifetime. So that is the description for people who have TB infection is no risk factors, and then which I treatment. So the reason is about 5% of the first 2 years after infections, and about 10% of over and lifetime. So TB infections and diabetes, so about 30% over lifetime. So the descriptions for people with the TB infections and diabetes and with no treatment and the risk of 3 times as high or about 30% of over lifetime. So TB infections and HIV infections about 7% to 10% per year. So the descriptions is for people with TB infections or untreated HIV infections and with no low latent tuberculosis infection treatments. The risk is about 7% to 10% per year. So a very high risk over of the lifetime. So anyone who has latent tuberculosis infections can develop TB disease, but some other people has higher risk than others. So the HIV infection is the highest risk factor for development of the TB disease. So in a person with the latent tuberculosis infections is owing or weakening of the immune system. Okay. The drug resistant or TB, so MDR or XDR. So the drug resistant TB is caused by microbacterial tuberculosis organism that resistant to the drugs normally that used to treat the disease. The drug resistant TB is transmitted in the same way as drug susceptible. So the TB is no more infection. The drugs susceptibles if TB, however, delay the recognitions of the drugs and resistance of prolonged periods of the infections may facilitate increased transmissions, further developing or the drug resistant. So, Monisha, ang drug resistant tuberculosis, so all TB with any drug resistant. The MDR TB with drug resistant to at least the first line drug is more isoniazid and rifampin. So the XCR-TV with drug resistant to the first line drugs isoniazid and rifampin and to specific the second lines of drugs. So often resistant to additional drugs, resistance of any pluric, quinoline, lon, and at least one of the three injectable of the second line of drugs. Drug resistance. The TB is caused by tuberculosis organisms that are resistant to the drugs that normally used to treat the disease. So, drug-resistant TB disease is transmitted in the same way as drugs susceptible. The TB is no more infections and a drug susceptible TB. So, multi-drug resistant TB. The multi-drug resistant TB or MDR TB is caused by organisms resistant to the most effective anti-TB drugs. Isoniazid rifampin. These drugs are considered the first-line drugs are used to treat the most person with a TB disease. The multi-drug resistance TB MDR is caused by organisms resistant to the most effective anti-drugs, isoniazid and rifampin. So the extensively drug resistant. So extensively drug resistant or TB is relative of the rare type of the drug resistant. The TB resistant to isoniazid rifampin plus fluoroquinolone, at least one of the three injectable second line of drugs, the amikacin, kanamycin, or capreomycin, because the HCRTV is resistant to the first line and the second line of drugs, so the patients are left with the treatment options that are more toxic, more expensive, and much less effective. So, type of drug-resistant TB disease. So, the drug-resistant TB disease can develop into two different ways. They're called the primary and then kanang secondary resistance. So, the primary resistance occurs in a person who are initially infected with a resistant organism. So, the secondary resistance or acquired resistance develops during TB therapy. It's either because the patient was treated with an inadequate regimens, did not take the prescribed regimens approximately, or because of the other conditions such as drug malab- malab- malabsorptions or the drug-drug interactions that lead to low serum levels. Circumstance in which exposed the person is is at increased risk of infection with the drug resistant. So the TB including the following: the exposure to the person who has known the drug resistant TB disease, the exposure to the person with the TB disease who had a prior treatment for the TB treatment, the failure or relapse, whose susceptibility tests or results are not known. So, exposure to a person with TB disease from the area in which there is higher prevalence of drug resistance, or travel to one of these areas. So the World of Health Organization tuberculosis MDR-TB or XDR-TB, in a 2008 report for the list countries with the highest prevalence of the drug resistant. So the exposure to the person who have continued have the positive smear and the culture after 2 months of the combinations of chemotherapy. So the primary and the secondary MDR-TB. So the primary MDR-TB is infected with the drug resistance organisms is caused by the person-to-person transmissions of the drug resistance organism. So the exposure to a person who have known drug resistance TB, who had a prior treatment for TB treatment failure or relapse. There is no susceptibility test results are not known. So it's from the area in which there is a higher prevalence of the drug resistance. Continue to have a positive smears and culture after 2 months of combinations of chemotherapy. So it travels in the area which a high prevalence of the drug resistance TB disease. The secondary is acquired or developed drug resistance is develops during the TB treatments. Develops because the patient was not treated with the appropriate treatment of regimens or did not follow the treatment regimens as prescribed. Di wa niya gi-follow ang mga treatments kanang so the and took the drug incorrectly. Gamit siya kuan pero sayop iyang kinuanan. Took the drugs irregularly. So malabsorption. So the drug-drug interaction causing slow serum levels. The TB classification system. The current clinical classification is TB for use in the United States is based on the pathogenesis of the disease. It is intended mainly in operationally framework for a public health or program. So this classification system provides clinical the opportunity to track the development of the TB in their patients. The healthcare provider should comply with the state of the local laws and regulation requiring from the reporting of the TB disease. So all persons with the class 3 or clinically active or class 5 or TB suspected, the TB should be reported proximately to the local or the state health department so that a patient should not be have a class 5 or classification for the 3 months. That money siya. Ang class O is not TB exposure, not infected. Ang type. Class 1 TB exposure, like no evidence of infections, like so class 2 TB infections, not TB disease. Class 3 TB clinically active. Class 4 previous TB disease, not clinically active. Class 5 TB suspected. The description is no history of TB exposure and no evidence of that tuberculosis infections or disease. Negative reaction of TCO, IgRE, history exposure of tuberculosis. Negative reaction to TSC or IgRA given at least 8 to 10 weeks of after exposures. So the positive reaction to TST or IgRE negative bacteriology studies smear of culture. No bacteriological or radiographic evidence of active TB disease, and positive culture for tuberculosis or positive reaction to TST or IgR plus clinical bacterial or radiographic evidence of the current activity. So may have the past medical history of the TB disease, abnormal but stable in radiographic findings, a positive reaction to TC or IgRE negative bacteriology studies or smear of the culture. No clinical or radiographic evidence of the curing active TB disease or signs and symptoms of active TB disease, but medical evaluation not complete. So tuberculosis outcome. So regarding of kanang the treatment outcome, so 30% were cured, and then ang 62.1% is completed sa ilahang treatment, and then 3.9% kay naay kanang namatay. 2.0% were default, and the remaining of 1 to 2% has failed treatment. So the overall rate of the treatment success is among the patient was 92.5%. So thank you, that's all. Have God bless.